cases in 2020 where I've done full mouth rehabilitation for a patient of mine. Implants, crowns, veneers, all of them in one case. And I don't really need to go to the lab. No need. Just send me the image, send me the STL files, let me check it. Do I like it? Do I not? Do I need to adjust? Do I need to modify my prostheses at the end? Can I check the occlusion? Yeah, I can check the occlusion here. I can check it. So if I'm happy with it, yeah, go ahead, process the prostheses. If I like it, if I see it, check it, everything's fine, I'm happy with it, deliver it to the patient. And you'll have a very predictable outcome, a very nice patient feedback. So, let me show you what I've been doing with digital dentistry. This is a case of mine, quite old. Needed smile design. So what we did is we took an impression. He had spacing, so did a digital wax-up, overlaid that digital wax-up into the facial scan. He was happy with it, started to do the preps, modified the preps, made sure that my margins are visible for my intraoral scanner, so I make sure that my intraoral scanner can see my margins, so I can scan them. And trust me when I say this, scanning is quite fast, scanning is quite easy. It's just like that. No materials, no messy stuff. Final outcome, a replica of the proposed design. Again, a happy patient. Not only that, I can use it for diagnostic tools. For example, this case, she came to me with a negative smile. So the patient didn't really like her smile. The canines were longer, she had spacing. When I scanned her, I found out that not only these issues are present, but also she had a class 5 lesions all over her anterior teeth. And I can scan and show her, show the patient, like, see, look, you have lesions there, you have cupping there. So you need to treat that. We need to do something about that. And then we proposed a design for her. We showed her the proposed design. She's happy with it, modified it. We could, yes, we could. And then after that, we started to do the treatment. At the end of our treatment, happy patient. Reversed the negative smile into a positive smile, and the patient is very happy. And that's her comment, right there on Instagram. This is another interesting case where a patient of mine, she went to different clinics, and they all told her that you have anterior wear. So you know what? You need to do all of your teeth, basically, because it's anterior wear, right? So I said no. Let's do something else. I know a technique. It's called DAL. We used to do it in the UK. Let's open the bite. Let's wait. Let's see. So basically what I did is this. I took a scan, and that's why I love digital dentistry. It's a tool for me, for my lab, for my patients, right? So I know that there is wear in the anterior area. I can take the scan. I can assess the posterior teeth through AI, through artificial intelligence, through my intraoral scanner. I can check the bite, and you can see the marks. You can see the bites, and you can see the anatomy of the posterior teeth. They're not worn down. So I told her, you know what? We'll just open the bite. And you know what? You can open the bite with a virtual articulator. You don't really need a physical articulator to open the bite. And just open the bite with a virtual articulator, separated the teeth, to allow the posterior teeth to over-erupt, which is the concept of DAL. And I left that patient like that, with an open posterior bite for about 6 months. And the literature says it takes about 6 to 18 months for teeth to over-erupt. Surprisingly, she came after 6 months. We changed the prostheses, and we established occlusion. Patient was happy. We only did minimal teeth. We did it all through digital workflow. No impressions, no face pose, nothing. Not only that, we can take the impression, we can assess if we had proper occlusion or not. If the occlusion is correct, is it properly distributed or not? And you can see in this that after we establish the occlusion, you have multiple occlusal contacts. This is what we thrive for, right? As prosthodontists, getting the proper occlusion there. And with the help of digital dentistry, we can achieve that. Another case, implants, no worries, we can do it. So this case came to me with old anterior crowns, so we assessed restorability. We found out that the teeth needed to be extracted. So I said, let's extract them. And instead, let's put implants. And after healing finished, we decided to restore those implants and restore those teeth as well. So what we did, take a scan of those implants. And then we send this scan, we send this bite to the lab to fabricate our final prosthesis. This is all done with digital. Multiple implants, multiple crowns, in one patient, in one case, using only digital workflow. And what I mean by digital workflow is not only scans. We're not only using a scanner. We're using a scanner. We're using a designing software in the lab. It depends. Different labs have different softwares. I deal with different labs, so I deal with different softwares. And then after that, they process this final prosthesis, whether it was 3D printed, whether it was milled, etc. So this is what separates digital dentistry from analog dentistry, is the different tools that we can use with digital dentistry. And this is another case. I really love this case. I really love this guy. His Ahmed. He came to me with an amazing implant placed by my colleague, Dr. Mahdi. But the implant emergence profile was a bit narrow, right? And as a prosthodontist, you need to develop the emergence profile. So I placed my temporaries and I played around with the soft tissue, and I managed to have a good emergence profile. If we wanted to take an impression for the emergence profile, it would have taken a lot of, work. But with a scan, it didn't. Literally, it didn't. So I did the emergence profile. I captured the emergence profile using my scanner. And then I've sent that to the lab. I told the lab, follow the emergence profile. So the final crown will be adapting on that emergence profile. And you have amazing results. This took me 10 seconds to capture the emergency profile. It would have taken me, 3-5 minutes to capture the emergency profile using regular impressions. So it saves time. Another case where, there are wires, ortho. Doctor came to me, implants are ready to be placed. So, doc, can you? I said, yeah, but don't remove the wires. Let's play around. So what I did is I took a scan of the implants with the wires on. After I did that, I took the bite with the wires on. We can't do this with analog dentistry. You need to remove the wires. Otherwise, you will have a mess. So I did that, and then after that, delivered the crowns with ease, with the wires on. And you can even print the models with the wires on. You can't do this with regular analog dentistry. And that's why I love digital dentistry. Another case with the amazing Dr. Mahdi. Patient came to us, remember? She had short crowns. We proposed crown lengthening. So what we did, planned it digitally. And then we proposed the design for her. We told her, you know what? We want your teeth to look like that, but we need to do crown lengthening. And we need to follow the crown lengthening exactly the same way that our final prosthesis is going to be, right? So we measured that, and we created a crown lengthening guide. And this was done, I think, 2 years ago. And Dr. Mahdi, kindly, he did the crown lengthening. He followed my surgical guide. Thank you so much. And then after that, final prosthesis. Copy, paste. Thank you. And with the guys in Voxel Lab again, we can send them facial scans. You can send them upper and lower impressions or scans. And they can fabricate this kind of surgical guide in a 3D manner. And I can show the patient my surgical guide that I'm proposing for her. I can show the patient the crown lengthening, how it's going to look at the end. And I can show her the final results. You cannot do this without touching the teeth. But we can do this with digital dentistry. We do it all virtual, nothing physical. And it's predictable. And that's why I love it. The next step is, merging all of these different files together. Merging facial scan with the intraoral scan. And then not only the intraoral scan we can merge to, we can also plan our implants, right? And in this case, we're planning to do implants for the patient, or at least just do a diagnostics whether we can do implants or not. So we can export the CBCT and superimpose this CBCT into the patient's mouth, into the patient's facial scan. And you can see that, quite accurate. And you can show the patient, oh, you know what? We don't have bone here. We don't have bone there. So we need to do bone grafting. We need to do sinus lifting. You can explain all of this to the patient. And he can relate to it. Not in a way that we can do it in an analog way, right? And that's why this is a great tool for us in our day-to-day clinic. And I've done it all, as I told you. I've done, soft tissue scans, hard tissue scans, implant scans as well. It's all feasible. And the reason why, and that's why I didn't want to bore you at the beginning of the seminar, the reason why there is abundance of literature supporting digital dentistry. There is abundance of literature supporting scanners, the way they work, how accurate they are, scanning implants, multiple, single, etc. There is abundance. And you can just do it with ease. And this is, again, why I love digital dentistry. Yes, we can do full mouth rehabilitations. Some of the guys in PROS, I think, are hesitant because not enough literature says we can. But I've done it. Upper, lower, full mouth rehabilitations. And I can design my final prostheses, check if they're fitting well, check if they're passive or not passive, which is very important. And I can even 3D print my PMMA trial. So I can check if I like my prostheses, my final prostheses, or I don't. In this case, the final prostheses I didn't like because it was canting from one side. So I marked that to the lab. I told them, you know what, correct that for me, please. And they did. And then at the end, amazing occlusion, amazing results, highly accurate, happy patient. And enough about me, enough about what I do. We can use it in different aspects of dentistry. We can use it in orthodontics, in indirect bonding, for example, where you can just scan and send it to the lab, and the lab can tell you where to bond your metal brackets. I know that orthodontists are probably one of the most dentists who use digital dentistry on a daily basis, but this is another way where it's mixed between conventional orthodontics and digital orthodontics. Not only that, they can even use this technology in placement of mini screws. And this is a case by Dr. Diaz. He's a very nice doctor in, I think, in Colombia, if I'm not mistaken, where he uses the digital to fabricate guides to place his mini screws to provide more anchorage for his orthodontic treatments. And I know that Dr. Ahmed Shimiri has done this case. This is not Dr. Ahmed's, but inshallah, next presentation, I will take your documents. You know these cases with sclerotic canals that you cannot really treat using endo? Well, yes, they're doing that now all over. And there is a guy here in Kuwait who did this, where they fabricate surgical guides, endo guides, to tell them where to drill and when to stop drilling when they're doing their endodontic treatment. And trust me when I say this, amazing results. Look at that. A shadow of a canal, filled canal. So it's not confined to prosthodontics. It's used by different specialties, even endo. And in this case, a nice case that I found a case report in the literature where a patient had a wonderful bridge. They didn't want to replace the bridge. But I know guys in endo, they don't really like to drill when there is a bridge because of the anatomy. It might differ. So what they did is they combined the CBCT with the intraoral impression or the scan, and they fabricated a guide, a drilling guide for their access hole. So imagine how accurate this is. This is quite accurate. In conclusion, sorry for boring you guys, but you need to switch. You need to switch now, because when you take a look at the market penetration of intraoral scanners in general, or digital dentistry in general, you will find out that the majority in the world is now here. The early majority, or early adopters. So most of the countries now, in the US, in different parts of the world, most of them is switching now into digital dentistry. And trust me when I say this, it's a learning curve, but at the end, you will know how to use it. It's quite easy. It's not that hard. And the reason why I'm pushing you guys to do that is, I know we take a look at the literature and we say, if it's not really supported by evidence, we don't really follow it. But the problem is with technology is it's too fast for the evidence to follow. You see, I've studied in a academic setting, and I know in order to have a published article, it takes 2-3 years. If I'm lucky, 1.5 years, right? The technology is too fast. You cannot keep up with the advancements, with the new updates within the digital field. And that's why I don't really rely on evidence. I do read it, I do have it as a guide, but I don't really rely on evidence when it comes to digital dentistry, because whatever I read now is probably outdated 1.5 years ago. So if I have a study that tells me this thing is accurate, I know maybe this thing is accurate 1.5 years ago or 2 years. If a study tells me that this printer is quite old or quite inaccurate, I know that this is an old study because I've used it. I've used it all. I've used intraoral scanners, 3D printers. I'm dealing with different labs. I see my cases, and I see the results. And the results are amazing. That's all for you today, and I hope that you enjoyed this quite fast lecture.
Thank you. Thank you, Dr. Faisal. So impressive, and what you mentioned earlier about Al Adan Hospital, I feel proud now working in Al Adan.
الله يسلمك.
Time now for questions. So anybody want me to pass him the mic?
يعطيك العافية دكتور.
الله يعافيك.
When I did the endodontic guide, I spent around 2 months comparing between different brands and different CBCT machines and different softwares also.
Yep.
So for the future,
Yeah.
what do you recommend me to use, either the software or the machine or the CBCT
Okay.
also?
Softwares.
Which is the best that I could take?
I can't say.
Because for endodontic use, I need to be very accurate.
I know.
So I spent 2 months coming and back.
I know. The problem is there is a lot of variables. You have the CBCT device, it's a variable. You have the scanner to scan intraoral is a variable. You have the designing software, it's a variable. But the thing is, if you use one of the top, let's say 5 intraoral scanners, you're in the safe zone. If you use one of the top 5 printers, you're in the safe zone. If you use one of the top 2 or 3 designing software, you're in the safe zone. Because most of the studies, when you take a look at them, I can't tell you now, but it's 1 or 2 softwares for the designing, 1 or 2 printers for the printing, 1, 2, 3 scanners for the scanning. So it's there. And again, this is quite old. So most of the studies are published, a year ago or this year. But it actually were with endo, especially with endo, you need to see the results and then publish your paper, right? So it takes time for healing. So it's quite old. But all in all, it's few scanners, few printers, few designing software, and all of them, they work. You use them, you don't know, but you use one of them, I'm sure.
دكتور فيصل يعطيك العافية حبيبي.
الله يعافيك دكتور.
سؤال سريع بالcrown lengthening digital guide.
Yep.
Do you really incorporate a CBCT as well? Most of the cases, because like when they send it to you without having a CBCT, it's just telling you like a soft tissue driven.
Yeah.
And once you just use a soft tissue laser,
Yeah.
you probably realize you're really in the
Yeah.
risk zone. I know Dr. Mahdi sent you one, but do you really, most of the time, like I supposed to be always, using a CBCT as well, right?
It depends on the periodontist.
The diagnostic phase.
Yeah, it depends on the periodontist. Some periodontists, they love to incorporate the scans with the CBCT, but they have to be more involved with the crown lengthening designing. So they can measure the bone, and then they measure where they're going to do the bone reduction. Others, they don't. So to me, most of the crown lengthening guide that I do is based on the diagnostic wax up and an average value of the biologic width. So that's it. And then at the end of the day, the periodontist can open a flap and check. And eventually, he will have to open a flap and check and modify according to the wax up or the surgical design, the surgical guide that we fabricated.
Thank you.
I think this is way easier than going into a meticulous, meticulous planning, and at the end of the day, they will not really follow it by the letter.
Thank you. Thanks a lot.
يعطيك العافية دكتور.
الله يعافيك.
Quick question, do you often struggle with the different file types, مثلا ال DICOM files من ال CBCT, ال STL files من ال intraoral scans, or is that something the software just takes care of?
It depends on the software you're using. I'm using multiple softwares. It depends on the CBCT device and software itself. So different devices are user-friendly, others are not. So to me, it depends. طبعا, I had help from my colleagues, of course. يعني my colleagues in perio, my colleagues in in surgery or max fax surgery, they quite helped me in recognizing how to manipulate or how to extract different files, how to convert different files into different formats. But all in all, it depends on the software you're using. If you're using a friendly software, it will be easy. If you're not using a friendly software, it will be difficult, of course.
Thank you.
Thank you, Dr. Faisal. I think we're going to end now. Please accept our certificate of appreciation.
صور يعني. يلا يا ريت. يلا يعطيك العافية.
موجودة.
عند الصورة المفروض.
لا اطلع لي عشان الدكتور عايز يكبر بس.
ايوه تمام.
بس تلبس دكتور.
هذه صح؟ نعم.
دكتور.
تكفى. يلا.
I'm honored to present to you our last speaker for today, Dr. Basil Basha. Dr. Basil Basha is a prosthodontic with a passion for digital technology. He completed his undergraduate degree from Virginia Commonwealth University School of Dentistry. Then, he specialized in prosthodontics at the University of Texas Health Science Center. He has a special interest in digital technology and incorporating it in his daily practice. Please welcome Dr. Basil.
Test, you hear me? Good afternoon, colleagues. Thank you all for coming to this discussion. I see some faces I know, but also many others that I do not. So before our discussion, just a quick introduction about myself. As mentioned before, I have graduated the Virginia Commonwealth University in 2017 as a general dentist. I then worked in Kuwait for 2 years before moving to San Antonio, Texas, where I have enjoyed a journey of development and training in prosthodontics. I've always had a keen interest in technology in my daily life, and prosthodontics, for me, married my tech and dental interests very well. I graduated last year and currently working as a prosthodontist in Al Farwaniya Hospital. Outside of dentistry, I'm a family guy and like spending lots of my time with my nieces, seen here. I also enjoy drone photography as well whenever the weather is nice enough to do so. And lastly, I have no guilt in confessing to you today that I like racing cars way better than I like anything dentistry has to offer. On that note, let's talk dentistry. To set the tone for today's talk, I'd like to start the day by a very quick introduction related to digital dentistry, just to provide you with some structure to it. And then we will follow by discussing some patient treatment with which I was able to maximize some of the biggest benefits of today's digital capabilities. For digital dentistry to be achieved, a certain workflow must be obtained. That comes in the form of data gathering, design of the involved object, whether in the form of crowns, bridges, splints, etc. This is followed by the manufacturing of this product via subtractive manufacturing like milling, or additive manufacturing like 3D printing. And lastly, all produced objects have some sort of post-manufacturing procedure, like the curing of a 3D printed model or the sintering of a milled crown in the furnace. It must be mentioned that it is okay to jump between the digital and the real world at any time in these 4 steps. It is also okay to repeat these 4 steps as you achieve multiple phases of a patient's treatment, as we will see later today. By the way, I'd like to stress the fact that as a dentist, you're only responsible for good data gathering. The rest is the lab technician's job. This makes getting into the digital field is actually easy. I can assure you that with our current technologies, you are able to fabricate literally any treatment modality in literally almost any restorative material with digital tech. You just need to find the lab for it. So, in terms of data gathering, this is where it all starts. At this step, you're essentially creating a digital version of your patient on your computer. In our dental world, this happens using intraoral scanners to obtain a direct scan of the patient without any impressions, or desktop scanners are used to digitize models or even impressions that represent the patient. And lastly, the CBCT, which is mandatory for the evaluation of hard tissues, including bone, teeth, and it is especially necessary when surgical procedures like implants or if there is a maxillofacial involvement. It is also worth mentioning that photography and 3D facial scanning are another set of tools necessary for full digitization of your patient. Following proper digitization of your patient, design comes next. Design softwares are vast, which makes them present a steep learning curve, but that also makes them collectively capable. Such softwares, generally speaking, aid in diagnostic workups, planning surgical procedures, fixed and removable treatment modalities, as well as occlusal devices like night guards and mandibular advancement devices for sleep. It is worth mentioning that we are at a day and age where anything you could think of and in any material can probably be achieved with a digital approach one way or another. When it comes to manufacturing, additive and subtractive manufacturing are certainly the main competing methods of fabrication in this field. Additive manufacturing, or 3D printing in other words, takes several forms in dentistry, where this technology specializes in printing resin blends and metals. 3D printing is desirable due to its ability to build things additively and therefore not being as wasteful to material. It also allows for the manufacturing of complex objects as the printing is activated via tiny lasers or screens of 4K and even 8K resolution in today's age. However, things to improve with this technology is speed, the available materials able to be printed, and the shrinkage involved with printing resins, possibly affecting fit post-manufacturing. One of the biggest developments right now is the ability to print zirconia. It's picking up good momentum and is showing good promise in terms of marginal accuracy, but needs more testing related to its mechanical properties. On the other hand, subtractive manufacturing, aka milling, is well known for giving the ability to manufacture superior materials compared to typical printed resins. However, because it uses tools or burrs for the milling process, the manufactured object details are limited by the shape and size of the burrs involved. It is also wasteful to material, as such tech mills objects out of a big block, wasting most of the block in the process of making your prostheses. Post-manufacturing is like the dirty secret of dentistry. It is what no one talks about, yet it is very important to deliver the prosthesis or appliance that demonstrates the physical properties that it's meant to have. The left image shows printed denture teeth. Printed prostheses are mostly made out of resin and need specific post-processing work, which involves alcohol washing to wash the outermost uncured layer of resin. This is then followed by a specific curing protocol, which may or may not involve heat. Errors in washing protocol can lead to dimensional errors, while errors in curing protocol can lead to errors in the physical properties of the material. On the right-hand image shows milled pucks. Depending on the material, specific post-processing protocols must be done for the material to reach its final dimensional and physical state. So we had a bit of an overview about digital dentistry. Today, I'd like to share with you the main benefits of digital technology by presenting some of my experiences in this field, to hopefully help everyone who is interested to join the ship have a couple more ideas related to maximizing the potential of the digital approach in their daily practice. We will concentrate today on 3 major benefits to digital dentistry, including being innovative, predictable, and practical, with examples showcasing these benefits in real application. Let's talk about how digital dentistry is innovative, related to using high-performance materials in conventional treatment modalities. And here we go. Meet Eloy, who I have met in my residency program. He came into the program with the following chief concern, and that was, I would like to explore my options to restore my teeth. His health history did not indicate dental treatment and is controlled with medicine. Due to the time limit we are trying to stay within for today, I will only discuss significant findings and diagnoses related to the diagnostic phase. To start, the left-hand image shows the patient in a closed state, where you can start to see drooping corners of the mouth. The patient's teeth on this image are actually separated, and so biting down led to significant reduction in the lower third of the face compared to the middle. On the right side, the patient at repose had an incisal show of negative 2 to 3 millimeters. Here we see the patient smiling on the left with high animation on the right. These photos start to shed light on the status of the patient's dentition, with significant tooth substance loss coupled with a corrupted occlusal plane. A look at his panoramic X-ray image reveals no pathology, with symmetrical condylar heads and normal sinus anatomy. For his age, I think he has a relatively low restorative index, which may be a good sign for his maintenance practices at home. The buccal images show us in more detail the amount of severe wear this patient presents with, mostly matching two-body in nature in the form of attrition, but also three-body noted on the upper right 5 due to toothpaste-toothbrush abrasion. In this maximum intercuspal position, we see that some posterior teeth have missed each other and just started walking to the other ridge, looking for someone else to live with. Sadly, there's no one to be found. Our findings are still confirmed in this image of the maxillary arch with the amount of severe wear and carious lesions on a couple of teeth. On the mandible, we can appreciate a wear pattern that gets more and more aggressive as we move more and more anteriorly in the arch, rendering the restorability of his incisors questionable. In this case, the patient's dentition was digitized via desktop scanning of his stone models. A quick mandibular design to restore a harmonious occlusal plane revealed central and lateral incisors that are non-restorable due to lack of future ferrule effect. Moreover, although crown lengthening may aid with this regard, elective endo would be needed in all of them to produce a core that is able to retain the future full coverage restoration. And unfortunately for the patient, finances were an issue here. Therefore, I presented the patient with a mandibular fixed rehabilitation via monolithic all-ceramic restorations, opposing a maxillary complete denture that is fixed or removable. The patient did prefer a fixed alternative, but due to finances again, elected for a conventional removable denture. Luckily, in this case, the maxilla presents with fair to good anatomical expectations for support, stability, and retention to host a complete denture. So, following maxillary cast surgery, a maxillary complete denture was designed. The immediate denture was manufactured via 3D printing, as seen on the left, while the mandibular digital design was turned into segments of shell provisionals for the posteriors and the anteriors separately. The immediate denture teeth and record base were bonded, polished, and glazed and were ready for delivery. Treatment involved the extraction of the mandibular incisors, preparation of all the future abutments, and immediate provisionalization using the shell provisionals as seen here. This resulted in a mandible that represents a harmonious occlusal plane and that is ready to receive the maxillary complete denture for function. So the teeth were extracted and the immediate denture delivered to the patient. Patient was very happy with the result at his 24-hour follow-up. At this time, several improvements could be achieved on his aesthetic result, as well as related to occlusal vertical dimension, as I have noted in the patient's follow-up. Prior to moving to the patient's definitive treatment, another iteration of the maxillary denture was designed and delivered to improve occlusal vertical dimension and to drive the design of his final denture. Speaking of his final denture, the mode of restoration planned for this patient is about to be a complete denture opposed by all ceramic restorations, which may risk wear of the denture teeth, especially when considering the way this patient initially presented to me. Has anyone here seen a complete denture with denture teeth completely worn to the extent shown on the image on the right? I sure have. I wanted to avoid tooth wear and the occlusal vertical dimension loss that the patient might experience at a high rate with such treatment modality. So I started looking for solutions on the literature and found several case reports restoring denture posterior support via splinted zirconia onlays to control wear. But they also reported possible risks related to cement failure of these onlays and aesthetic risk due to the difficulty to match the stain-resilient zirconia with the wear and stain-vulnerable acrylic resin teeth, for example. Moreover, such zirconia onlays have been reported to fracture in areas where they happen to exhibit thinness and where they've been adjusted. To eradicate these issues, I have decided to do as follows. And that is to design and create custom-made denture teeth fully out of monolithic zirconia. So I went back to the digital world after scanning the patient's most recent models of the maxilla and the mandible and designed his definitive restorations to resemble the mutually accepted provisionals. In doing so, I have created the patient's mandibular crowns and bridge and made a splinted set of monolithic zirconia teeth to be incorporated to his record base for the maxilla. If you look at the apical aspect of these maxillary teeth, you will find cylindrical shapes milled out of them by design to 1, reduce the weight of the prosthesis, and 2, to retain the zirconia and the acrylic of the maxillary denture. These maxillary teeth were designed such that they index on the mandibular restorations, allowing for picking them up to the maxilla via regular base plate wax to then be processed like any other conventional denture. Following the delivery of the mandibular crowns, we obtained a very nice rehabilitation for this patient with an option that ensures a long-lasting denture opposing this patient's mandibular rehab. In this example, digital dentistry allowed to provide a complete denture with superior tooth properties given to the patient's treatment modality, which would otherwise be compromised in the conventional workflow. A second major benefit of the digital dental approach is predictability. This is because it aids us in visualizing the final result on the digitized patient, providing no risk related to pure chance, kind of like how Dr. Faisal just showed us. To visualize this, meet Linda, who was 60 when we met. Linda had been diagnosed with scleroderma, Sjogren's syndrome, cervical dystonia, all of which secondarily led to depression as a result. This led her to have the driest mouth I surely have ever and probably will ever see, meaning removable treatment is not desirable due to tissue irritation, and fixed treatment on her existing dentition can very easily lead to secondary caries due to her condition. Upon maximal smile animation, we see that this patient also has a hypermobile lip, showing a gummy smile on her right side. Intraorally, we can all start to appreciate the amount of dryness and the very interesting shearing of enamel that started happening for the past 2 years after her medical diagnosis. Due to the patient's medical conditions, extreme high caries risk, progressive limited mouth opening, further complicating future hygiene on her dentition, the patient elected to edentulate both arches and rehabilitate using implants. This is obviously a controversial treatment option, given her dentition is restorable. But the patient and myself were concerned that her worsening mouth opening and high risk for caries would mean paying all this money on fixed treatment only to have it fail in a 5-year timeline due to caries and starting to lose her chance for implants due to the limited mouth opening in the near future. So the patient was digitized via intraoral scanning in this case, coupled with CBCT and facial scanning as well. This combination will, as we will see, provide us with the basis needed for a predictable treatment aesthetically and functionally, as the patient was adamant to have fixed treatment in every step of the way. Following virtually edentulating the patient, and a digital design of her new occlusal scheme was aesthetically driven by her facial scan. The aggressively threaded Straumann BLX implants were planned for this patient to maximize our chances of immediate loading. Complete dentures were also designed and printed in case immediate loading was not possible. clinically due to bone quality or implant stability. With immediate loading in mind, surgical guides were designed such that a stackable set of bone reduction guide seen on the left precedes the implant placement guide seen on the right. And so the second implant placement guide was designed to fit magnetically and mechanically to the bone reduction guide as seen in this video. Moreover, for immediate loading and based on the aesthetic design shown before on the facial scan, an immediate load prosthesis was designed to also stack magnetically, allowing for easy and hands-free loading of these implants. Let's see how that actually worked out. So on the top left image here, we see the palatal jig that carries the first bone reduction guide to its correct orientation to be fixed in bone via fixation pins. Here, we see the stackable implant placement guide. And this is both guides stacked together magnetically. And lastly, the immediate load prosthesis 3D printed out of composite resin. Clinically speaking, the treatment was initiated with the extractions of the patient's dentition, and the maxillary bone reduction guide was fixated to the bone. This reduction was necessary to hide the margin of the final full arch hybrid above the patient's highly animated lip, if you remember from the beginning of the diagnostic phase. The use of the magnets in this case helped in retention of the implant guide hands-free, providing an easy approach to implant placement. The immediate load prosthesis was then stacked in a similar fashion and temporary cylinders picked up via polymethyl methacrylate resin. Thankfully, immediate loading was possible on 4 out of the 6 planned implants, and the remaining 2 posterior implants were left to heal for conventional loading in the definitive hybrid, as they had some lack of initial torque. For the mandible, immediate loading was also a goal, but this time, all her mandibular dentition was to be extracted except for the most distal molars, which were strategically used to support the implant's guide and immediate load prosthesis. They were extracted after the loading of the implants has been complete. Also, luckily, enough initial implant placement torque was achieved for loading purposes, and so implant loading was achieved as described. Here is the patient obviously before and after. In this case, treatment was predictable from an aesthetic and functional standpoint, thanks to the implementation of digital dentistry available to us today. And with a team of dentists and lab technicians that are complementarily capable, the benefits of digital dentistry can be maximized. And lastly, to the practical example of digital dentistry. I have a rather short case, courtesy of Dr. Hassa al-Bahar from Mina Clinic. I have had the pleasure to help her with this patient, and I thought it was an interesting approach where digital dentistry proves itself to be very practical. This patient was 13 years old when she showed up to the clinic. She presented with a history of dental trauma 2 weeks prior, where the upper left one was avulsed and, of course, discarded by the patient's parents. Treatment options included an implant, but the patient is too young for that. Removable partial denture was not an option of interest to the patient nor to the parents. Resin-bonded bridge was another option. And lastly, if you look closely on the occlusal view on the right side, the upper left 5 is begging to be used for auto transplantation. The literature has pretty good evidence for the success of such approach in the anterior maxilla, though the reviewed evidence was of weaker quality, as it was mostly involving case reports and such. The risk and benefits of this treatment option was discussed with the patient's parents, and they elected to attempt the procedure. And here's where digital dentistry turned out highly practical. Because the only thing used in this case is to digitize the patient with a CBCT scan for hard tissue purposes. We can examine this site of the avulsed tooth and the state of the buccal and palatal plates, as well as the upper left 5 planned for transplantation. With today's technology, artificial intelligence can be utilized to automatically segment any tooth of our choosing to be able to create a model replica of it. Moreover, because we can create a digital copy of the tooth, the auto-transplantation can also be simulated in the existing socket, to have an expectation related to available bone to house the tooth, as well as the amount of bone osteotomy needed to fit the tooth. So after the whole procedure was simulated digitally, as seen on the right-hand image, the tooth replica was printed with surgical guide resin and was sterilized. This way, the auto-transplantation was practically achieved as seen in the blue circle, while the actual tooth stayed in its socket. This is done to minimize the possible damage to the PDL of the tooth and to be able to extract and immediately auto-transplant the actual tooth with no delay. The treatment ended with splinting the tooth in place for 1 week, after which root canal therapy was administered to the tooth. And here's the patient 3 weeks after treatment, healing nicely, with the mobility of the tooth drastically reduced at this stage. And so the tooth was reshaped by Dr. Hassa via rotary instrumentation, and composite resin was used to gain this beautiful result for this young patient, allowing them to function, live a normal teenage life until future intervention is possibly needed when they grow into adulthood. So, to conclude, digital technology allows for a more innovative, predictable, and practical approach to dentistry. It allows for efficient and effective patient communication in all fields, including orthodontics, where clear aligners and simulated orthodontic treatment is made possible. It is also effective, of course, to visualize and monitor the rate of tooth movement during ortho treatment, while providing the basis for effective maxillofacial planning and execution of treatment to correct skeletal issues. Surgically speaking, multiple approaches have been developed to restoratively drive surgical treatment, including endosteal and custom-designed subperiosteal implants. Digital technology is not anymore an emerging field in dentistry. It is a very quickly developing one. What is emerging now is things like artificial intelligence, 4D printing, zirconia printing, and insane improvement to 3D printing speeds never seen before. I encourage you all to join this field and not be intimidated by any possible learning curve. Practice makes good, and good makes you happier. Thank you for listening, and I wish to talk to you again in the future about those emerging technologies and how we can hopefully implement them in our treatment in the near future.
Thank you, Dr. Bassel. Does anyone have any question? Thank you, everyone.
There was a question. Right there.
Thank you for the great lecture, Dr. Bassel. Just which software are you using for the digital planning?
For planning, surgical planning, specifically is Blue Sky, personally. Actually, a combination of Blue Sky and Mesh Mixer.
Okay, thank you very much.
You're welcome.
يعطيك العافية.
Allah يعافيك حبيبي.
Regarding the auto transplantation, you know the roots of the 5 is quite different than the central. So how
Absolutely.
can you do the manipulation in the socket before
Right.
you extract the tooth and replant it? in
I
the socket?
don't know if I can have the screen back to go back to the photo. If not, that's okay, but there was an image shown on the right side of one of the slides showing the segmented tooth here. Right there, on the right-hand side image, you can see the segmented tooth itself tested within the CBCT socket of the avulsed tooth. Now, that gives us an idea related to where the bone reduction must be made in order to fit the replica. And so it simply gives you an idea as to where you should aim in terms of bone reduction, that's all. And so Dr. Hassa essentially did what is expected, you know, the palatal, in this case, palatal reduction of bone until she was able to fit the tooth replica, and that's when she extracted the actual tooth and transplanted it. Thank you all.
Thank you everyone for attending our last lecture for today. We hope you are going home with valuable information. Thank you.
السادة الأطباء أعضاء اللجان، أرجو الحضور. أطباء الأسنان اللي ساعدونا وكانوا باللجان معنا أرجو التواجد. حياكم.
وينك؟ نادي اللجان. الله يعطيكم العافية. في أحد بعد؟ مساكم الله بالخير جميعا ويعطيكم العافية كلكم. إن شاء الله ما راح نطول، ربع ساعة ثلث ساعة راح إن شاء الله. ندري تعبانين من صباح الله خير وثلاثة أيام أو 4 أيام ورا بعض. نحاول كل سنة نغير شوية من نظام حفل الختام، بدل ما يكون في لوية وعشاء وروحة وردة. إن شاء الله نمون عليكم. أتوقع بهالطريقة راح تكون شوية أريح. الفكرة كلها بس شوية كلمات شكر، شوية توصيات، شوية ملاحظات ممكن ناخذها. أنا اليوم يمكن حبيت إن ما كنت أبي يكون في عريف حفل يحتاج إنه يقدمني ولا يقدم باقي أعضاء مجلس الإدارة. لا، أنا اللي أبي أقدم باقي أعضاء مجلس الإدارة، أنا اللي بقول الشباب شنو اللي سووا. على السريع بالبداية يمكن أول شيء تغير عندنا بهالمؤتمر إن إحنا كان عندنا نوعا ما شيء مختلف عن كل سنة، اللي هو البري كونفرنس اللي هو سيمبوزيوم الإمبلانت. رابطة اللثة ما قصروا، مشكورين على جهدهم وتعاون اللجنة العلمية اللي هم بعد ما قصروا، أخونا دكتور فهد البصري ولجنته. جزاهم الله خير على التنظيم والمجهود الرائع اللي تعاونوا فيه مع رابطة اللثة. بداية بس نوجه تحية حق رئيس رابطة اللثة دكتور أحمد الشراد وهو وأعضاء لجانه، وإن شاء الله يستمر هذا الشيء للسنين الجاية أفضل وأفضل. يمكن طبعا كل سنة لازم في أخطاء، لازم نتعلم من أخطائنا وملاحظاتنا. هالسنة اللي يمكن الشيء اللي صار مختلف وغير ان احنا كل يوم الملاحظات قاعد ندونها اول باول. السنين اللي طافت يخلص المؤتمر فرحه المؤتمر واللويا وهذا وننسى كل شيء. اللي قاعد يصير ويانا هالسنه ان لا قاعد نكتب ملاحظاتنا اول باول، نسمع من الاودينس اللي موجودين، نسمع من اللجان، نسمع من الناس السبيكرز نفسهم. يعني في اخطاء ان شاء الله راح نتجاوزها المره الجايه. طبعا كثير من الاطباء ما شاء الله الوجوه اللي انا قمت انسى خلاص شيبنا، يعني قمنا ننسى الوجوه، بس في وجوههم نفسها تتكرر كل سنه، وهذا شيء وايد يفرحنا ويخلينا اطمن بالمؤتمر لما نشوف الناس اللي اوريدي شغاله من قبل، عارف ان هذا ما نحتاج ياخذ الانستركشن، عارف انه راح يعرف يتصرف، عارف ان الروتين شلون راح يصير. وطبعا يمكن انا ارجع واقول انا الشخص الوحيد اقل مجهودا هذه السنه. الشباب اعضاء مجلس الاداره قصروا، ابتداء من رئيس المؤتمر والامين العام الدكتور اياد المقيط، ما قصر جزاه الله خير، نوجه له تحيه. طبعا رئيس اللجنه العلميه اللي هو المؤتمر قايم عليه اللي هو دكتور فهد البصري، هم جزاه الله خير. يمكن وايد تحمل مني نرفزه وزفيته وايد، بس ما قصر صراحه، يعني صدره رحب، جزاه الله خير ما قصر. وطبعا هم دكتور بصيص اللي هو لجنته ما يحتاج بعد، هو مجهودهم الواضح. والجنود الخفيين دكتور عبد العزيز الجزاف اللي ما قصر باللحظات الاخيره، دائما يدش ويعطينا ابداعات. والتجوري مالنا دكتور سعد الشمري اللي مناشي بالعالم كله وما قصر هم بعد هالمؤتمر. ورئيس اللجنه الاعلاميه وفريقه الدكتور محمد الحمادي. كل سنه كان كل لجنه تكون بروحها وشغاله بروحها، وبعدين يصير شويه يعني خلينا نقول تداخل يصير في تداخل بالمهام. هالسنه هذه ومن السنه اللي فاتت خلاص صارت كل لجنه تشتغل مع اللجنه الثانيه، كلكم صرتوا لجنه واحده. يمكن في لجنه بس طبيعه عملها مختلفه، وهم نحب نوجه لهم تحيه، لجنه المواصلات مع الدكتور عمران جزاهم الله خير. هذول اللي نريح بالنا بس نعطيهم الكشف وهم قايمين بالواجب مو مقصرين. جماعه بس انا عشان لا نطول عليكم، كل سنه ارجع واقول انا قاعد اتكلم واشكر واقول، ما احتاج اني اقول واشكر زياده. انتم عارفين يعني ايش كثر تقديرنا لكم وايش كثر ودنا نشكركم من هني نقعد اسبوعين ما نخلص. اللي قاعد تسوونه هذا شيء وايد مفرح. انا واحد من الناس اشتغلت كل الاشياء اللي انتم سويتوها، انا اتكلم عني شخصيا. اول ما تخرجت اشتغلت مع الجمعيه، كنت عضو باللجان، مسكت رئيس لجنه، عقب تدرجت صرت عضو بمجلس الاداره، امين صندوق، امين عام، رئيس، ومشيت بهالطريق هذا. حتى لو كنت مو ماشي بهالطريق، حتى لو كنت بس مجرد شغلي باللجان هذه والعمل الاجتماعي، يعني بروحه هذا يكسب شيء كبير، يعرفنا على الناس، يعرفنا على المجهود، الناس تعرفك، المجتمع مالك افضل من ما انت تكون طبيب قاعد بروحك بعيادتك وتمشي. صدقني في يوم من الايام محتاج مشوره زميلك، محتاج تعاون من صديقك، محتاج تعرف الحياه مالتك راح تصير مختلفه وتحب العمل مالك. ودي بس كل واحد من اعضاء مجلس الاداره، يمكن ما كنا نسويها، ما اهم ارجع واقول عقب ما يخلصون كل اللي راح نسويه كالتالي. الحين نسوني، الحين راح اكون انا كاني عريف الحفل وانظم العمليه عشان نخلص. اوكي، نبي بعد ما نخلص ما راح نقوم تكريم واحد واحد عشان لا نطول، ادري راح تملون، لان لو انا مكانكم كان مليت. راح يكون في لكم شهادات التكريم وخلينا نقول يعني هديه تذكاريه بسيطه. بعد ما نخلص كل واحد موجود بالاسامي ياخذها، اللي مو موجود بعد مشكله نلتمس له العذر. ارجع واقول يمكن انا دائما يقولون ان اجريسيف شويه مع الناس، ولكن عندي نقطه ان ما احب اساوي اللي اشتغل باللي ما اشتغل. اوكي، يعني لما جينا فتحنا باب التسجيل حق اللجان، اللي سجلوا 300 وشوي سجلوا يبي يشتغلون باللجان، واحنا اساسا في اللجان الاساسيه اللي كانت موجوده باساس الجمعيه يعني قريب 80 90 شخص باللجان، فما خذينا عدد كبير من الناس اللي سجلت. طيب صار عندنا عدد ما شاء الله وافي وكافي، طلعنا فيه تفرغات، قعدنا فيه باجتماعات، وبالاخير اللجان هذه لازم ان احنا نقدرها ونكرمها ولها يعني معامله خاصه، سواء من تسجيل، سواء من تعامل، سواء بالمستقبل يطلبوا اي شيء له اليه مختلفه. طيب بما ان انا حسبت الشخص هذا من ضمن لجاني، انا ما اقدر اراقبه واتابعه واقول له تعال ابصم واشوف منو داوم ومنو ما داوم، بس ما يصير اساوي الناس اللي قاعدين 24 ساعه قدام الباب، الناس اللي قاعد تشتغل وتروح وترجع وتوصل الناس اللي قاعد تبترع الورك شوب، ما ابي انسى مهمه اي احد، ما يصير اساوي بواحد بس سجل اسمه وقاعد بالبيت. فاللي في ناس من عندنا راح تشطب اساميهم، في ناس من عندنا ما راح نفكر حتى بالسنين الجايه يدشون ويانا، كل اللي موجودين وفي مننا مو موجودين عشان لا نظلمهم، جزاكم الله خير، مشكورين على مجهودكم. حاليا احنا ودنا احنا نوجه لكم تحيه انا واعضاء مجلس الاداره على مجهودكم الاكثر من رائع، مشكورين وما قصرتوا صراحه. احتاج من يمكن مو مرتبه، بس انا حتى اللي مو متعود انه يقوم ويقول اي شيء ولا كان منسق، انا راح احتاج من كل واحد من اعضاء مجلس الاداره لو نص دقيقه او دقيقه كلمه حق الاطباء، وعقبها يا جماعه راح نروح ناخذ الشهاده والهديه ونتوكل على الله ونشوفكم ان شاء الله بالمؤتمر الجاي. ابي نبلش بدكتور اياد وبعدها الصوره الجماعيه ان شاء الله.
مساكم الله بالخير. انا الحين كمساعد دكتور محمد قاعد يتكلم على اللي اشتغلوا باللجان، بس انا قبل لا اتكلم عن اللي اشتغلوا باللجان واللي موجودين واللي كانوا موجودين معانا، بعرج على نقطه اللي هي السيمبوزيوم اللي بري كونفرنس اللي كان للبريو. للامانه انا مره ثانيه اشكر اخوي الدكتور احمد، وما بي اي والله وما بي انسى دور الدكتوره منيره ابو راشد. للامانه انا قاعد اشوفها من قبل المؤتمر، من قبل الكونفرنس، بس هذول الجنود المجهولين اللي احنا ما تكلمنا عنهم. ايضا في واحد موجود كان من قبل لا نبلش بالمؤتمر ومن قبل لا نسوي اجتماعاتنا كان يشتغل معانا، وهذا تلقونه بكل مكان، تلقونه بنسيله، تلقونه ببدريه، تلقونه بالمعرض، تلقونه برا. دكتور مهند اي والله. واخر جندي مجهول انا صراحه هذا الولد اللي احطه على يميني امشي وانا مرتاح، وهذا كل سنه للامانه يبدع. طبعا هذا قبلنا يبلش ويخلص عقبنا، ايهاب السيد، بس ما ادري اذا موجود هسه الحين كله ينحاش ما يقعد شو اسمه. بيض وجوهكم. انا قمت بس من باب مسؤوليه اني كوني رئيس المؤتمر اني اشكركم، وقالها الدكتور محمد تمساع ما له داعي، يعني هو شكركم كلكم، وانا ارد مره ثانيه اكرر، وان شاء الله يا رب نلتقي. وطبعا هذا مو حفل، للامانه مو حفل، بس يعني احنا ودنا بس نشوفكم ونقعد معاكم، لان انتم تستاهلون اكثر من ان نقدم لكم درع ولا نقدم لكم هديه، ومشكورين وما قصرتوا.
وين ابو حمد عزيز؟ شباب حتى اللي هذا لو نص دقيقه راح اقومكم واحد واحد، مو تقول لي ما عندي شيء، راح تقول حتى لو دقيقه.
مساكم الله بالخير، يعطيكم العافيه جميعا، شخص دكتوره بس مشكورين. وين اي كان هناك. يعطيكم العافيه. صراحه انا هني بهالمكان بلشت من 2013، اول مره دخلت فيه المجلس كان حلم حياتي ان نوصل مستوى مؤتمراتنا مستوى العالم، مستوى اللي نروح نشوفه باوروبا وامريكا، في ستاندرد كنا نمشي عليه، نشوف الشيء العام ما كان موجود، بس كان حتى وقتها المؤتمرات العالميه ما كانت متطوره مثل ما صارت الحين. كل سنه نروح نشوف برا شنو جديد نحاول نسويه هني، حتى لو ما نضبط اللي وراها يضبط. اي شيء تشوفونه برا تتمنون يكون عندكم الكويت، احنا هني موجودين مستعدين نسويها. كان لكتشر تايب، ديبيت، ورك شوب، هاندز اون، كل انواع اللي ممكن تشوفها انه يتطور الطبيب قاعد نحاول نوصل لها بطريقه او باخرى. بس الامانه في ناس تجيبونهم ونحطيهم فلوس ونحطهم كسبيكر وجولدن وكذي، بس ما يعطيك اللي تبيه، ما يعطيك غير لما يكون تروح لمكانه او تروح لكورسه. احنا هنا حاولنا نقصر الشغلتين هذول ان نسوي ورك شوب. بالورك شوب الدكتور يعطيك اكثر، يعطيك تريكس، يعطيك شغلات تسويها بالسيرجري، غير عن المحاضره العامه اللي يعطيك الصوره العامه ان شلون الحالات قاعده تصير. مره ثانيه يعطيكم العافيه، شخص ودائما المؤتمر يكون قيامه باليوم الاول، واليوم الاول كان مجموعه البيريو ورابط البيريو بالتيك اوف. دائما المؤتمر يكون باول يوم، وانتم ساعدتونا وايد بالتيك اوف الاولي، وظلينا كذي فوق ليه هاليوم. قواكم الله.
السلام عليكم.
عليكم السلام.
يعطيكم العافية، والله يعطيكم الصحة والعافية، مشكورين ما قصرتوا. طبعا أنا أقل واحد وجودا بينكم يعني، لكن الكلمة الأكيدة اللي أقول لكم إياها، فلوسكم كانت بأمان. هذه الأكيدة يعني أنتوا اللي قمتوا بالمؤتمر من إلى. أنا بس وظيفتي أني أطلع لكم الفلوس، أقصد لكم المبالغ فقط لا غير. بس الأهم شنو يكون أن الفلوس بأمان. وأنتوا الله يعطيكم الصحة والعافية. أنا أقل مجهود حتى من الدكتور محمد اللي كان يقول عنه يعني محمد يقول أنا أقل واحد فيهم، أنا أقل من الدكتور محمد. لكن أنتوا الجنود المجهولين اللي موجودين بالمؤتمر كامل، والله يعطيكم الصحة والعافية ومشكورين وما قصرتوا.
كن بعد.
مساكم الله بالخير. أنا أول مرة أتكلم معاكم كذي، زين. الشباب ما قصروا كأعضاء مجلس الإدارة. اللجنة العلمية كانت عبارة عن جميع الأطباء اللي دشوا المؤتمر، لأن كانوا يصورون ويسوون منشن حق KDA، فالخطة مشت. كلكم صرتوا أعضاء اللجنة الإعلامية، تمام. نجاح المؤتمر أنتوا اللي نجحتوا المؤتمر بشغلكم بمجهودكم. الكل تعب، هد بيته هد عياله الفترة هذه كلها تعب. النتيجة كانت وايد واضحة حتى على ضيوفنا، حتى في الغرف الصغيرة اللي داخل كنا نشوف الفيدباك من الناس، الكل مستانس. قواكم الله، وإن شاء الله المرات الجاية إن شاء الله أكثر وأكثر. راح أنتوا في منكم يعني شلون أفهمكم، ما عارف شلون أعبر، بس إن شاء الله شيء واحد راح يكون شيء وايد قوي إن شاء الله في المستقبل. مشكورين ما قصرتوا.
يعطيكم العافية. أنا سألت سؤال، أحد عرف الإجابة؟ كم منظم كأس العالم قطر؟ ما عرفت. محمد دشتي يعرف الإجابة. كم منظم كأس العالم قطر؟ كم عدد المنظمين؟ ما أعطوهم تفرغات، إحنا أعطيناهم تفرغات. لا تغشمر وياكم، رايتكم بيضة تستحقون تفرغ. والله العظيم لو كنت أنا وكيل وزارة، صعبة ها؟ بس والله لو كنت وكيل وزارة لأعطيكم أسبوع بأسبوع، لأن التعب الحين بيبين معاكم. رايتكم بيضة، جزاكم الله ألف خير، ما قصرتوا. يعني أنا وأنا ما أدري جروب من الجروبات، واحدة من البنات تقول هذه مو غلطتنا، الثانية تقولها ماكو غلطة الحين، ماكو غلطة. يعني هذا يكفينا. يعني يمكن أنا أشارك الشباب بحكم أنهم معي بجروب، التشكرات اللي توصل بالجروبات، يمكن بعض الامبلنت سمبوزيوم وصلتهم عن طريق الانستغرام. ترى هذا كله لكم. حنا لترالي ما سوينا شيء. اللي كان يوصل الساعة 2 بالليل لجنة المواصلات تسلمه إلى لجنة استقبال، الشباب قاعدين بالفندق للساعة 2 بالليل. يمكن البعض ما تشوفونه ترى وياكم بالفندق، بس هو قاعد من المطار إلى الفندق، من الفندق إلى المطار، والشباب اللي بالفندق جزاهم الله خير مادين واجبهم. صراحة فردا فردا صعب جدا. أنا كان ودي أذكر الأعضاء واحد واحد، صعبة. بس ودي ما أنسى محمد شتيل الغائب الحاضر، حكم أنه اعتذر ما يقدر يجي. يستاهل أبو جاسم، ما قصر، رايته بيضة. وحدة يمكن أصلا مو مسجلة باللجنة المنظمة، بس موجودة أكثر من اللجان المنظمة. الدكتورة هنون البعيجان يعطيها العافية موجودة معانا من الامبلنت سمبوزيوم، حكم انها صاحبة منيرة يعني. هذه بعض المرات تصير يعني سوى عليك الله يعينك. فرايتكم بيضة يا جماعة، يعني أخجلتونا وأحرجتونا. احنا كمان عظامة إدارة خذينا الكريدت وإن الكل يتشكر، لكن فعلا فعلا الشكر لكم واحد واحد. أقل من حقكم، لكن مثل ما قال محمد الكل تعبان، فشيء خفيف لطيف بحقكم. جزاكم الله خير. ما أنسى أبو محمد فهد البصري على المشاكل اللي صارت والعطلات اللي صارت، هو وأعضاء لجنته جزاهم الله خير ويعطيهم العافية. الدكتورة كوثر العلي كذلك ما انساها، يراسلون من 5-4 شهور ترى قاعدين يشتغلون. كذلك أبو فهد أياد ومهند مع المعرض شغالين من 6 شهور. يمكن أنا تشوفوني موجود بالميدان لأن أنا شغلي بالميدان، بس اللي قبل كنت ساحب على الربع، ما أدري فعلا إن كل واحد قاعد يقوم بشغله الحمد لله رب العالمين. طبعا دشتي طقة متواضعة أول مرة يسويها، بس ترى موجود جزاه الله خير، وهو اللي حمال الأسية. يعطيكم العافية، ما قصرتوا يا جماعة.
يعطيكم العافية جميعا. أنا راح أختصر، الشباب ما قصروا. راح أشكر كل اللجان فردا فردا، بس راح أخص شوي، راح أتكلم عن اللجنة العلمية. اللجنة العلمية أول مرة أنا دخلت سنة 2019 فشفتها أن هي كور الجمعية. اللجنة العلمية إذا نجحت مع احترامي كل اللجان، المؤتمر ينجح، الجمعية تنجح. اللجنة العلمية أنا أخصهم بالشكر واحد واحد، ما راح أذكر أسامي، عبد الحميد يطالعني، سلمان يطالعني، كوثر يطالعني، كلهم اشتغلوا معي من 5 إلى 6 شهور يوميا. يعني أنا ماني قايل، في أسامي موجودة، منى العميرة أدق عليها 4 الفجر بس عشان تسوي لي الجدول. دكتورة لمياء تكلمني 2 الفجر بس عشان والله إنه دكتور يبي يغير تذكرته. فأنا أشكركم واحد واحد. طبعا مهند ما أقدر أسولف عنه، والشكر الموصول حق ربعي مجلس الإدارة إنهم أعطونا الثقة إحنا كلجنة علمية. وفي كان تدخلات يعني الساعة 4:30 5:30 من دكتور محمد دشتي، يجيني آخر وقت يعني قبل مؤتمرنا اليوم. متى سوينا إحنا السيمبوزيوم؟ سيمبوزيوم الساعة كم كان؟ الساعة 12. الساعة 9 يدق علي يقول لي في شاشات جديدة بنحط احنا الصور والشهايد انطبعت جديدة. فأنا أشكركم كلكم واحد واحد، وأطلب من الدكتور عمران بس يتفضل. تفضل دكتور عمران. في شيء أعضاء مجلس الإدارة ما يدرون عمران شو مسوي. جماعة هذا الريال يسهر عندي بالديوانية ليه 5 الفجر بس عشان يوزع الرحلات. فأنا أشكره جدا وحاب كلمة حق ربك.
مساكم الله بالخير جميعا. طبعا كلكم ما قصرتوا كلش، ما حد فيكم قصر. قاعد أشوف احنا هم تعبنا، كلكم تعبتوا. عساكم على القوة إن شاء الله كل سنة كذي ينجح المؤتمر ونستانس بشوفتكم.
وقواكم الله.
تحت قيادتكم.
بس لحظة شوي فهد.
لحظة بس، في أبي دكتور أحمد الشراد أنا.
بالضبط أنا
إيه
ناديه عشان أقول كلمة يعني بس.
تفضل دكتور. حياك.
بسم الله الرحمن الرحيم. ماكو كلمة بعد كلمة الشباب أعضاء مجلس الإدارة. اللي صار نجاح حق الجمعية، الكل قاعد يتشكر ويقول مثلا رابطة اللثة، دكتور أحمد، دكتور منيرة، هو شغل جماعي. أنا يقولوا لي أبو علي، يقولوا لي السنة الجاية سوها بروحك برا الجمعية. قلت ليش أسويها بروحي؟ نجاح السيمبوزيوم من نجاح الجمعية. أبد إحنا معاكم، إحنا رابطة الجمعية، ما نتفرق إن شاء الله من شيء. هذا كله الكريدت حق القطاع كله، يعني حق التخصص. صراحة أنا أحب أشكر يعني كل فريق اللي اشتغل معنا. التحضير صار له أكثر من يمكن 10 شهور. الجروب كان جدا متعاون. الحمد لله توفقنا باختيار المحاضرين، باختيار المواضيع، وكانت إضافة جميلة حق المؤتمر الجمعية، وإن شاء الله نكررها إن شاء الله. جزاكم الله خير.
مشكورين يا شباب على الكلمات الطيبة. يمكن آخر مرة راح أكون واقف وياكم على الستيج إن شاء الله. السنين الجاية الشباب فيهم الخير والبركة يكملون مشوار الجمعية والمؤتمرات، وكلهم ما راح يقصرون بإذن الله. ويعني يمكن أرجع أكون واحد من الناس اللي تشتغل باللجان، وهذا شيء صراحة يشرفني. ويعني أعتقد أن السنين الجاية تعلمنا من هالمؤتمر وايد، ما فينا يعني ما في كلمات نقدر نضيفها فوق اللي قالوا الشباب. سامحونا على القصور، سامحونا. أنا استسمحكم باسم كل أعضاء مجلس الإدارة إذا أحد شد مع أحد يمكن ضايق أحد منكم. أنتم أمانة ما قصرتوا، وإن شاء الله منها الأعلى للجميع. الحين بس نطلب منكم كلكم إذا تقدرون صورة جماعية، صف أول ثاني ثالث، صورة جماعية، وعقبها ناخذ الشهادات. وتصبحون على خير ونشوفكم بإذن الله السنين الجاية. قواكم الله.